All right. Good morning, everyone. Um, it's my pleasure this morning to introduce Dr. Michael Osborne. He's a physician scientist at Mass General and assistant professor of medicine at Harvard Medical School and associate director of their nuclear cardiology lab and education at MGH. He's completed undergraduate training in Vanderbilt University with a major in biomedical engineering. He did his medical school at the Chicago Medical School and then medicine residency and cardiology and nuclear cardiology at Brigham Women's, as well as a research fellowship at MGH. He joined MGH in 2018 and has served in a key role in launching their PET program, um, and as well as and expanding its roles in nuclear cardiology, preventive cardiology, and cardiac rehab. He's received Excellence in Teaching Award from the Cardiology Fellows in 2019 and 2020, and was nominated for the HMS Mentoring Award in 2020. His research is currently funded by the NIH and the American Heart Association, which focuses on imaging to identify early markers of disease and elucidating of underlying physiological mechanisms, with a primary interest in evaluating the impact of interventions on neuroimmune pathways linking chronic psychosocial environmental stress to cardiovascular disease. He's taken national leadership roles with the American Society of Nuclear Cardiology, and has been part of the Leadership Development Program and was awarded ASNC's 2023 Rising Star Award. So we're very honored to have Dr. Osborne here today. He's going to be speaking on his title is Getting Under the Skin, the Neurobiological Mechanisms Linking Chronic Disease and Cardiometabolic Disease, which is highly topical for us in that we have the brain-heart interconnectome led by Dr. Liu, which is a major initiative for the university. So we're very pleased to have Mike here today and look forward to his presentation.
Thanks so much, Dr. Beanlands, and thank you very much for the invitation. It's truly an honor to be here and to chat with you and get to see the Institute and meet with so many folks. So I'll go ahead and get started. All right, quick disclosure slide, nothing pertaining to the talk. So my objectives today are going to be to review PET imaging of metabolism and inflammation in humans, discuss the link between chronic stress and cardiometabolic disease, and the mechanistic insights that we've been able to derive from nuclear imaging. I also want to discuss the impact of socioeconomic, environmental, and genetic factors on these pathways, and then spend some time speaking about potential interventions and future directions in this line of work. So the first slide is just a basic slide showing some of the PET tracers that could target pathophysiologic mechanisms in atherosclerosis. As you all know, there's a number of potential tracers that can be used targeting different processes that are at play in the development of atherosclerosis. One of the most useful and widely studied, including by individuals at this institution, is FDG. So FDG is a radioactive glucose analog tagged with fluorine 18 that enters the cell through a glucose transporter, becomes phosphorylated, and then gets metabolically trapped as it cannot proceed through glycolysis. So this allows it to identify and aggregate in tissues with high metabolic activity. So commonly used for imaging of malignancies as well as inflammation because of their high metabolic uptake of glucose. So FDG uptake in the arterial wall has provided a useful index of atherosclerotic inflammation. It's not necessarily specific for inflammation, and I'll talk a little bit more about that. Nevertheless, it does its uptake does correlate with macrophage density. And as you can see here in both a PET image and in a histopathological slide, the regions of high FDG uptake do correspond to regions of increased macrophage density. And this finding has been recreated in a number of studies from different cohorts. We also know that arterial FDG uptake is predictive of adverse cardiovascular disease events, and this has also been recreated in a number of different studies. So, it not only is a useful marker of macrophage density, but then that also has some inclination towards identifying a more vulnerable patient that may be at risk for a downstream event. As mentioned, there's several important limitations of using FDG for atherosclerotic imaging. Most importantly, it's not biologically specific. So we know that a lot of cells in the arterial wall are going to use glucose. This includes smooth muscle cells, as well as vascular and perivascular cells. And while it does correlate with macrophage density, macrophages are not the only cell that takes this up. It's also very difficult to compare values across studies. This is mainly due to differences in imaging techniques, as well as differences in technology with PET cameras. Image analysis is challenging, as I'm sure several folks in the audience can attest to. One of the most challenging aspects of the analysis of these images is to get the correct background and avoiding spillover from neighboring tissues, because especially in the carotids, it's a very busy area that's prone to difficulties with measurement. And last but not least, because of uptake in the myocardium that's physiologic, it is very challenging to image coronary arteries. That's compounded by the fact that the heart is moving, and PET is often a summed image that cannot be gated. So one of the unique aspects about FDG PET, on the other hand, is that it can be used to evaluate multiple tissues simultaneously. Because of that lack of specificity, you can actually leverage it to look at metabolic activity in a number of different tissues across the body at the same time. So if you get a whole body PET image, you're getting a metabolic map from the entire body. You're also getting an attenuation correction image, whether that be an MRI or a CT scan, that allows you to look at other factors that may be present at the same time that you're acquiring these images. So within this paradigm, you could imagine a situation where you're looking at atherosclerotic inflammation, you're looking at activity of inflammatory tissues, such as the bone marrow or spleen, you're looking at brain activity, and you could be looking at findings from CT, which could be as simple as coronary calcium, or even looking at things like adipose tissue depots. So leveraging that paradigm, we became interested in using this to better understand systems biology approaches to gain insights into the pathophysiology underlying links between risk factors and disease. So one of the very poorly understood links that has been known for centuries is the link between stress and cardiometabolic disease. So if you look at epidemiologic studies, the attributable risk for cardiovascular disease related to chronic stress is on par with smoking, hypercholesterolemia, hypertension, diabetes. We also know that common psychosocial stressors and stress conditions associate with CVD. So for example, greater risk for cardiovascular disease events and depression. We also know that stress links to a number of cardiovascular disease risk factors, but that underlying biology to date has been relatively poorly understood. What we do know about the pathways linking stress to cardiovascular disease is that it involves several physiologic pathways, but what really has been missing is how does stress enter the system? So we know that high levels of stress activate the hypothalamic pituitary adrenal axis. This leads to release of stress hormones like cortisol that can increase your cardiovascular disease risk factors. It tilts your autonomic balance in favor of the sympathetic nervous system. It also leads to direct vascular effects, including increased vascular reactivity and coagulation. And the downstream consequence of many of these factors is heightened inflammation. So really the argument is that because of this increase in inflammation, there's an opportunity to increase all sorts of adverse processes in the human body. Some of these insights have been gleaned, I should say, from animal studies. So from the work of Dr. Matthias Narendorf and Phil Swirsky, which was done largely at MGH and now at Mount Sinai, we know that when you stress a mouse, so in their early experiments, they would put a cat on top of a mouse's cage, which you could imagine would be highly stressful. They were able to identify increased bone marrow activation in these mice that was actually due to direct input to the bone marrow from the sympathetic nervous system. The bone marrow then spits out more inflammatory cells that go to the spleen, where they proliferate and differentiate, and then they migrate out to the periphery. And one of the places they often go, as you can see in this optic image of a mouse that was not stressed versus a mouse that was stressed, is to the arterial bed. And that leads to atherosclerotic progression and potentially destabilization of those plaques. So you could hypothesize that there's an analogous system in humans where adverse lifestyle that would include, decreased stress would lead to the activation of these leukophoretic tissues, increased leukopoiesis, and then increased peripheral inflammation, including atherosclerotic inflammation. So taking a step back, so understanding how stress enters the system becomes important. It's not simply that the stress itself is activating these pathways. However, you would imagine that stress probably comes in through the brain. And everybody's concept of stress is different. Everybody's reaction to different stressors is different. So you have this paradigm where everyone is prone to a reaction to stress, and everyone is exposed to stress. Those with high reactivity and high stress exposure are probably at the greatest risk for these downstream consequences of stress activation, whereas those who either don't have a lot of stress or exposure or may be less reactive to stress, or potentially you could use the word resilient, would have less of this activation and potentially less disease that results from stress. So which brain centers are involved in this is a really challenging topic. There's a lot of intertwined connections, and we know that there's not a single center that is your stress center. However, one of the most primordial centers in the brain that is involved in the stress response is a center known as the amygdala. And there's two amygdala in every human on both sides. It's a limbic system structure that is located near the brainstem. And it's really involved in the initiation of fear, the fight or flight response. So I always sort of say that is the first center that if you saw a tiger walk in the room, that would be what would initially cause your response. However, the amygdala, has its response, but not everybody responds in the same way to that particular stress, and that's because of inputs from other stress centers. So one of the more important additional stress centers is obviously the cortex. That's what differentiates us from many other animals in the animal community. And the thought would be that while you're experiencing this heightened amygdala activity, well, let's say there's a glass panel between you and that tiger, your prefrontal cortex can say, it's okay, you don't need to run away, and can sort of override that stress response. There's certainly other centers that are involved. However, it does seem that the prefrontal cortex is one of the most important structures in sort of rationalizing and contextualizing that stress and creating such a balance. So Some early work that predated my involvement in this line of research and was largely led by my mentor, Ahmed Tawakol, started to look at the metabolic balance between the amygdala and some of these regulatory structures. So he came up with a concept that, and I'm sorry, I apologize that it goes back and forth in this study, but I want you to when you see the words amygdala activity, just know that that represents this concept of stress-associated neural activity, which again is the ratio of amygdala metabolic activity to that of the cortex. So we know from primate studies that increased amygdala activity associates with anxious temperament. So the more anxious a monkey is, the higher their ratio of activity is. We also know from other studies that this ratio is increased in individuals with chronic stress conditions, including PTSD, and that this is stable without an intervention over approximately 3 months. So it may give you an index of a person's stress reactivity that's relatively stable over time, that could correlate with some of these downstream physiologic processes. So what Ahmed Tawakol hypothesized was that this heightened stress-associated neural activity would actually drive the front end of this pathway that was identified in animals, wherein it would increase activity in the bone marrow and leukopoiesis, increase atherosclerotic inflammation, and lead to a heightened risk for adverse cardiovascular disease events. So what he did was he initially tested in a prospective cohort of individuals who actually had PTSD. And this was only 13 individuals, but he did a perceived stress scale at the time of their imaging and found that amygdala activity or stress-associated neural activity indeed correlated with their perceived stress. So that's a very crude questionnaire that's about as crude as it gets. If you get caught in traffic before you take it, you're going to answer the questions differently than if you had an easy ride into work. We also saw that perceived stress scale correlated with arterial inflammation and also with a C-reactive protein. So it gives some hint that this may be a useful endeavor. So he then looked at a retrospective cohort of individuals who had FDG PET CT for clinical purposes, largely for malignancy screening or staging, and a total of 293 patients without active cancer or without known cardiovascular disease were identified. And interestingly, in this cohort, this stress-associated neural activity, again, associated with atherosclerotic inflammation, as well as bone marrow activity, but there was no association with a comparator tissue in this case, which was subcutaneous fat. So all of these measurements were done as target to background ratios using FDG uptake in the tissue. For the brain, the background was again the cortex. For the vasculature and bone marrow, it was the venous blood pool. Furthermore, in that cohort, over a period of 5 years, this brain activity was predictive of adverse cardiovascular disease events. And again, these were people that didn't have baseline cardiovascular disease. This was interestingly independent of a number of risk factors, including those for cardiovascular disease, prior malignancy, psychiatric history, and even their Framingham risk score. Furthermore, in his analysis, he showed that using mediation analysis, that the link between stress-associated neural activity and arterial inflammation was in fact mediated by bone marrow activity, and the link between amygdala activity and adverse cardiovascular disease events was mediated by atherosclerotic inflammation. So it really gives you a sense that this pathway may indeed be valid, at least in this particular cohort. So it's always important to look to other cohorts to gain confidence in your findings. So this was a study done at the NIH by Nehal Mehta, looking largely at a population of individuals with psoriasis who don't have baseline cardiovascular disease as well as healthy controls. He had coronary CTAs and PETs acquired in close proximity to one another for all of these patients, and was able to show that heightened stress-associated neural activity, again, associated with increased bone marrow activity, as well as atherosclerotic inflammation in this cohort. But he was able to also extend that and show that these individuals also had a higher burden of high-risk coronary plaque features on their coronary CTA. And another study of individuals, I'm sorry, this is a little displaying a little bit challenging in a challenging way, but individuals after a myocardial infarction, so 45 individuals without MI and 17 controls, they saw similar correlations where brain activity, again, correlated with atherosclerotic measures and bone marrow activity. But they used two different questionnaires to look at the relationship with brain activity and saw both the PSS10 and the PHQ-9 had strong associations. And what was really interesting about this study was the brain activity not only associated with atherosclerotic disease, but it also associated with the complexity of their atherosclerotic disease. So they used different criteria, basically deeming their disease as complex, non-complex. They used TIMI flow, and they also use syntax scores to illustrate this point. And then finally, in a more recent study, it's been shown that this SNA in individuals who recently had a stroke predicts subsequent cardiovascular disease events. So you can see this paradigm where it's individuals who have physiologic stress, individuals who have chronic stress, individuals who have no baseline cardiovascular disease but have a systemic inflammatory process like psoriasis. This pathway seems to hold true. So when I started working on this line of research, some of my initial work was trying to tease out the relationship with metabolic diseases that increase risk for cardiovascular disease. So in that same cohort that was initially used with the retrospective PET-CTs that were acquired for clinical purposes, we were able to show that individuals with higher baseline stress-associated neural activity had higher baseline visceral adiposity. They also, in individuals who had follow-up PET-CTs, which were 68 of the cohort, it predicted a higher gain of visceral adiposity on their interval imaging. We also found that among those who did not have baseline diabetes, those with higher stress-associated neural activity had greater risk for the development of subsequent diabetes. And interestingly, that development of diabetes was independent of their baseline adiposity measures. So it wasn't simply that they were gaining weight and becoming diabetic. There was more going on with the biology there. And in another study that used a separate cohort, we've always been interested in Takotsubo syndrome, which is sort of the quintessential stress-associated cardiac disease. So we were able to identify individuals who had PET-CT and before an episode of Takotsubo syndrome. And we were able to match them to individuals who did not develop Takotsubo syndrome. They had the same cancer, same age, same sex, similar risk factors. And what we were able to show that among those who developed Takotsubo syndrome, they had higher stress-associated neural activity on this baseline CT. And as you can see here in this plot, and interestingly, not only did it predict Takotsubo, but those with the highest stress-associated neural activity actually developed Takotsubo syndrome sooner. So it predicted both timing and incidence of Takotsubo syndrome. And then I was discussing this a little bit last night because this was a surprising finding to me, at least. But we also looked at the impact of stress-associated neural activity on malignancy outcomes. So you can imagine that many patients with a newly identified malignancy will undergo a baseline PET for cancer staging. After cancer staging, people often get the same therapy. Some people respond well to therapy, some don't. In this particular study, we showed that their baseline stress-associated neural activity actually helped to differentiate that group as to figure out who survived without progression. They had the lowest activity. Those who survived with some progression had the middle amount of stress-associated neural activity, and those who died from their disease had the highest, significantly higher stress-associated neural activity. So again, we always think of cancer as a process that it involves the immune system in responding. So you could imagine that a hyperactivated immune system is going to be an adverse thing, and that could be particularly prone to being driven by stress pathways. This, I should add, was independent of stage, age, stage of malignancy, age, and sex as well. So we know it associates with all of these diseases, but one of the key questions has become, what is driving this? Because until we know what's driving this activity, and we've identified risk factors for this high activity, there's not really much we can do about it other than treating a downstream effect. So we became interested in that initial cohort in looking back retrospectively and trying to identify some of the risk factors that may be driving the front end of that pathway. So we looked back at home addresses at the time of their PET scan, and we were able to use census data to pull their neighborhood median income. And very interestingly, we found that there was indeed an inverse association with I should say stress-associated neural activity. I apologize for going back and forth, but these slides are prompting me to say the wrong thing. But there was an inverse relationship between income and SNA. And there was an inverse relationship between income and atherosclerotic inflammation. And in the cohort, this is not at all surprising based on the data that we know that adverse socioeconomic status predicts cardiovascular disease events. Those with the highest income had the lowest cardiovascular disease risk, whereas those with the lowest neighborhood income had the highest cardiovascular disease risk. Oop, did it freeze? Stinking. There we go. We're good. Okay. So, and then again, attaching the income to the front end of those mediation models that I showed earlier, again, we were able to show that the link between socioeconomic status and adverse cardiovascular disease events was mediated in series by stress-associated neural activity, leukopoietic activity, atherosclerotic inflammation, which culminates in MACE. And I should add, I don't know how familiar you are with mediation models, but just walking you through this. So each of these arms is significant. And this is the indirect pathway, right? So the direct pathway would be the link from A to B. So when you walk around A to B, it's significant. However, when you look at the link between socioeconomic status and MACE and you take out this indirect pathway, so you say the link between socioeconomic status and MACE, aside from the link accounted for by these other factors, that was actually non-significant. So this argues that the primary driver, at least in this population, may indeed be this stress-associated neural pathway. We also did some research and found that there's a lot of data linking adverse noise exposure, and noise is a funny definition, just like stress, because some people's noise is other people's music. But there's a link between noise exposure and amygdalar activation on fMRI. So one of the quintessential studies of this was actually they exposed people to dental drills, which I think everyone would agree is noise, and their amygdala lit up when they heard that sound. So we became interested in whether noise exposure, which has also been linked with adverse cardiovascular disease events, may be driving this pathway as well. So we had at the time had a really interesting tool available from the U.S. Department of Transportation that allowed us to measure noise at an individual's home address from neighboring roadways and air traffic. So we went back and acquired all of that data as well, and performed a very similar analysis to what we did with the income. What we saw was individuals with lower noise exposure tended to have lower stress-associated neural activity. And again, the same pattern held true for atherosclerotic inflammation. And noise was predictive of adverse cardiovascular disease events. Again, that was independent of a number of potential confounding factors. You have to always, whenever you're thinking of noise, you have to think of air pollution. You have to think of socioeconomic factors because these things often run together in deprived areas. We used both the WHO cutoff for unhealthy noise is 55. Just to go back, that would be similar to something between rain and a conversation. But again, that's continuous 24-hour average if you were exposed to that level of noise, as well as a lower number, which was 45 decibels, and the same held true there as well. Much of, and again, just as an aside, a lot of the noise exposure is one, it's probably annoyance, but there's a lot of literature suggesting that it's the nighttime noise that's the most unhealthy, probably related to startle and inadequate sleep. So it's really that 24-hour average where if you think you're living, under a common path for planes or along a busy road where you're going to be constantly sort of startled and you can never fully settle, that's probably the most unhealthy form of noise. And again, the mediation pathway in this model worked as well, wherein higher levels of noise exposure drove higher stress-associated neural activity, atherosclerotic inflammation, and MACE. So another thing that is potentially a driver that I think we could all agree on is that maybe there's genetic influences that impact how a person responds to stress, right? So now that we have different tools that allow us to measure someone's genetic propensity towards different psychiatric traits or even disease states, we became interested in whether there was a possibility that higher genetic risk for a stress-sensitive state might be related to this pathway as well. So interestingly, neuroticism, which has commonly been associated with stress sensitivity, has been long associated with coronary artery disease. And we noticed from some UK biobank studies that the polygenic risk score for neuroticism is associated with adverse stress diseases. So you look here at its relationship with depression, and it's also strongly associated with an increased risk for coronary artery disease. There's also a lot of genetic overlap between genes that predispose you to neuroticism as well as coronary artery disease. So it really does argue that there may be some connections on that front as well. So more recently, we've leveraged a larger cohort of individuals from our institution. There's an institutional biobank, and what we did was we went back and pulled the individuals who had this polygenic risk score for neuroticism and who had PET imaging, and we were able to look to see who had events. And we collaborated with a group that had access to the UK biobank as well. In the UK biobank, they don't have PET imaging, but they have MRI imaging. So we were able to look at some potential imaging correlates of stress-associated neural activity by leveraging the UK biobank. So in the MGB biobank, which is Mass General Brigham, there's approximately, there were 995 patients in our cohort. In the UK biobank, there were 21,000 patients in this cohort that provided both imaging and genetic data. So in the MGH biobank, not surprisingly, as we hypothesized, the neuroticism polygenic risk score associated with stress-associated neural activity when we split it by tertiles. And then in the UK biobank, we were a little bit surprised to see that the NPRS tertiles correlated inversely with amygdala gray matter volume. Now, you could say, why would a smaller amygdala be more active? There's literature stating that an amygdala gets larger when it has more regulatory inputs. So when you get more input from the cortex and regulatory centers, the amygdala will actually get larger. So you could argue that you would want a larger amygdala rather than a smaller amygdala. So it's a little bit paradoxical there. Furthermore, when we looked at whether neuroticism polygenic risk score predicted events, we saw that in the MGB biobank, there was at least a non-significant trend in overall MACE, but there was significance when we limited it to ACS events, whereas in the UK biobank, there was a significant relationship across both types of events. We also looked at the brain measures again, and we saw significant results aside from amygdala volumes with ACS MACE using both amygdala stress-associated neural activity and amygdala volumes in both biobanks. So again, we did mediation. We looked here at whether amygdala gray matter volume mediated the link between neuroticism, polygenic risk score, and MACE, and it did indeed. And this was an unadjusted model. This was adjusted for cardiovascular disease risk factors. Because we saw some attenuation of the effect by including cardiovascular risk factors, and because of some of our other findings with stress-associated neural activity, we wondered if rather amygdala volume was in part leading to increased MACE by heightening cardiovascular disease risk factors, and we indeed saw in this mediation model that that was true as well. So we basically have this paradigm now where we know all of these upstream drivers towards stress-associated neural activity, everything from income, crime rate, stress questionnaires, stress disorders, noise exposure, adverse medical events, leads to increased stress-associated neural activity. We know that that drives increased atherosclerosis, increased inflammation, increased endocrine diseases. It's even been associated with lower bone density by a group in Korea, and a number of adverse cardiovascular disease events. I didn't talk about some of these, but we've also shown that it increases the risk for DVT. And one of the other interesting things that I'll touch on later is we've shown that individuals with higher stress-associated neural activity may have a lesser response to statin therapy. So the question is what can we do about this? If we were able to modify someone's SNA or stress-associated neural activity, would that lower their cardiovascular disease risk? Is it the stressor by itself, or is it the combination of the stressor plus the response? So in that original cohort, we sought to evaluate this concept of resilience. So what we did was we looked at individuals who had exposure to one of these socioeconomic or environmental stressors, be it increased noise exposure, increased crime rate in the neighborhood, increased income or decreased income in the neighborhood, I should say. And what we looked at was we did a 2x2 where we said, we're going to put the stress-associated neural activity on the left side, and we're going to put the presence of these risk factors on the x-axis. And we sought to really stratify individuals based on how much stress-associated neural activity they had in the presence or absence of chronic stress exposure. So we hypothesized that those with lower neurobiological resilience would be those that would sort of fall in this top left, whereas those top right, and those with a higher neurobiological resilience would actually be the individuals who have lower stress-associated neural activity, even though they're exposed to stress. And what we found that even among those who were exposed to stress, so same quantum of stress, different stress-associated neural activities, the stress-associated neural activity still predicted events. So that really raises the question of how do we intervene on this? So if we could lower someone, we can't necessarily take stress away, right? We can't give people money. We can't just with a magic wand stop crime or make noise go away. There's certainly things that you can do from a policy level, but it's not going to fix everything. So it really creates this paradigm where we need to think about intervening on this pathway potentially. So you think about what could we do for the brain? Well, there's obviously pharmacologic options. There's a number of lifestyle options. So we know that exercise improves brain health. You could think about stress reduction. For as far as the bone marrow activation, maybe you could use beta blockers to block that sympathetic nervous system to the bone marrow and attenuate the inflammatory response. You could also just go way downstream and give everybody who's stressed a statin, but nobody's going to be excited about that, or even think about another anti-inflammatory agent. So I mentioned this briefly, but I found this incredibly interesting. So we had a study of 40 individuals who underwent PET-CT before and after initiating statin therapy. And they either started a low dose of atorvastatin, 10 milligrams, or a high dose of atorvastatin. And we found that individuals who had higher baseline amygdala activity had a greatly attenuated response to statin therapy. So you can see here, there was barely any budge for individuals who started 10 milligrams. And if you look at the 80 milligram dose, it was about a 50% lesser response in their change in arterial inflammation. So they wwere re-imaged with PET-CT, I should add, 12 weeks after starting the statin, or 3 months after starting the statin. And then there was a similar relationship among CRP among the same people. So this argues that not only is this driving disease, but it may also be attenuating the response to standard therapies that we're giving individuals. So the question, we're really seeking is what can we do to potentially attenuate this stress-associated neural activity, because that's going to have the greatest effect. Now, this is I was sort of on the fence about presenting some of this data when we found it, but we ended up deciding to proceed with publication because we thought that it represented a nice proof of concept. There's certainly reasons not to drink alcohol, but there's always been this sort of paradigm in cardiovascular disease with the J-shaped curve that moderate alcohol intake may actually lower your cardiovascular disease risk. Now, we know that it increases your risk for all sorts of other things like cancer, potentially lowers your brain health. But just as a proof of concept, we leveraged the Mass General Brigham Biobank, which in this case was around 100,000 patients with outcomes data and about 300 patients with imaging data. And we were able to show that individuals with light to moderate alcohol intake tended to have lower SNA. Obviously, those with high alcohol intake tended to have higher SNA. And, interestingly, in this particular cohort, there wasn't a huge hit on overall brain activity among those with light to moderate alcohol intake, but there was with higher intake. Furthermore, we showed that the effect of light to moderate alcohol was associated with a lower risk of MACE. And again, that was mediated by this lower stress-associated neural activity. So this does argue that alcohol might be a way to attenuate, or might represent a pharmacologic mechanism by which you could attenuate the stress-associated neural activity, but we would certainly want a different agent rather than advising our patients to just go start drinking. We wanted to expand this to the larger data set to see if it was just a phenomenon in our imaging data set. So what we looked at was the impact of light to moderate alcohol intake in individuals with pre-existing anxiety. And what we found was that there was a greater reduction in MACE risk with light to moderate alcohol intake in individuals who had baseline anxiety, using anxiety as a proxy for high stress-associated neural activity. And that held true with both any MACE as well as MACE limited to 10 years after their enrollment into the biobank. And we found an interaction there between anxiety and pre-existing anxiety and light to moderate alcohol intake for its impact on MACE. So this does, again, sort of suggest that the pharmacology may be right, the treatment may be wrong. We also looked at exercise. I don't think anyone's going to get upset about talking about exercise to see what the effect of of exercise on the brain is. We know that exercise improves brain health, and it actually is one of the most common things that psychiatrists recommend for their individuals that they see with stress conditions. So we thought that that impact on stress may actually be one of the under-recognized cardiovascular disease benefits. So interestingly, with exercise, we found that as your exercise increases, your stress-associated neural activity decreases. Now, this was primarily driven by impact on the prefrontal cortex. So remember that stress-associated neural activity is that ratio of amygdala to prefrontal cortex. So you're increasing the denominator by increasing your exercise. And then again, the relationship between higher physical activity and adverse cardiovascular disease events. In this, we stratified physical activity as above or below the guidelines, which is 500 metabolic equivalents per minutes per week. And then, so we, above or below, those above had lower MACE risk. And again, that risk was mediated by its impact on stress-associated neural activity. Again, as a sort of proof of concept to test whether individuals with stress-associated conditions, in this case we use depression, might interact differently with exercise than the general population. We looked at the impact of exercise across across quintiles on MACE in the broad population, and we saw that there was basically a plateau effect around where the guidelines recommend, right? So guidelines recommendation is right here along this green box. After that, the average person doesn't gain a lot of benefit from more exercise on its MACE effects. If you look at individuals without depression, we see a similar curve. However, when you look at individuals with depression, they continued to see benefits as they exercised more. So it does argue that the higher your baseline stress-associated neural activity is, you may have an opportunity to lower that further by an intervention. And this is sort of illustrating that same concept. Again, using the same paradigm that we used in the alcohol study for anxiety, we looked similarly at depression, and we found, again, that the combination of high levels of exercise with coexisting depression, there was an interaction for the effect on MACE reduction. Okay, I'm thinking again here. All right. Maybe. Uh-oh. We've only got 9 more slides, so we're getting there. I don't know if I should have. Oh, there we go. Just needed you to walk in and scare it. Thank you. So the other area that I've been very interested in is some of these stress reduction techniques. And, you know, stress reduction research is historically very messy. It's biased because the people that are doing it believe in it. The people that they're bringing into their programs believe in it, and they actually invest in it. Every stress reduction intervention is different. So you look at the literature, there's no homogeneity across these different stress reduction strategies. But obviously, if we could impact the brain through stress reduction, that might be a useful thing. So there was some relatively almost a decade old now research from one of the meditation scientists at Mass General, her lab, Sarah Lazar, that utilized a stress reduction intervention from the Benson Henry Institute at MGH. So Herb Benson was a cardiologist who was a big believer in stress reduction techniques and in meditation. And he devised a program that's 8 weeks for teaching different stress reduction strategies. So what Sarah was able to show using MRI before and after the stress reduction intervention was that there was a change in amygdala gray matter density over the course of that treatment period that correlated with their change in perceived stress. Now, you could say these people didn't gain anything from the program because they actually became more stressed through the stress reduction intervention. However, those that participated in it did actually gain a benefit. They modified their brain. So their amygdala became more dense. And again, thinking back to that concept of larger amygdala have more inputs, you could argue that a denser amygdala probably has more regulatory inputs as well. So one of the principles that they're always teaching at the Benson Henry Institute, who I've started collaborating with, is transitioning from a bottom-up way of thinking, which is letting your amygdala drive you, to a top-down way of thinking where you're letting the cortex and your higher brain levels sort of govern your actions. So this may support that notion. This was also a seminal study, not done at MGH, but this was done at the University of North Carolina. It was a randomized controlled trial looking at patients who were cardiac rehab eligible, looking at the impact of no intervention versus standard cardiac rehab versus cardiac rehab plus stress management training. And what they were able to show was that the individuals who went through the combined program had better survival at 5 years than individuals who just went through cardiac rehab alone. And again, we don't fully understand these mechanisms as to why this may be the case. We also know that from these other messy and ubiquitous studies that stress reduction appears to reduce inflammatory biomarkers, also attenuates gene expression related to inflammation. So there was a study done, again, using the Benson Henry Institute intervention that showed that the NF-kappa beta pathway is ratcheted down by stress reduction techniques. We also know that a number of cardiovascular intermediaries appear to be impacted by stress reduction. That includes an improvement in blood pressure. There was a study out of Samia Bokhari's group that showed an improvement, a trend towards improvement in myocardial blood flow. Some studies have shown reduced adverse events, reduced carotid intima media thickness. There was a large meta-analysis that was published in EHJ this year that suggests that psychological therapies for depression, so non-pharmacologic therapies, may actually lower your risk for adverse cardiovascular events. And it should add that a number of studies have shown that these interventions appear to be most effective in people who come in with a higher level of stress. So my research has been my prospective research, I should say, has been focused on looking at the impact of a stress reduction intervention on this pathway. So I had a 2-year training grant that happened during COVID that was very challenging to recruit for. But what we were interested in that particular study was taking individuals who endorsed high levels of stress, doing PET-MR imaging before and after randomization to a stress reduction intervention to see if individuals who went through the intervention may have a greater impact on this particular pathway than those who did not. I've since transitioned to a longer career development award, and now we're looking at the same intervention in individuals with stable coronary artery disease. And we're just under 50% recruited, and I probably have 5 gray hairs for each of the patients that we've recruited for this study. Our inclusion criteria are probably a little strict, so it's been a good learning experience from a clinical trial design standpoint. But in our prelim analysis of the first 9 patients from this study, we actually got really remarkable results. We were underpowered to look at the downstream effects, but we were able to show that individuals who did not go through the intervention actually had an increase in their stress-associated neural activity while they waited for the intervention after their second imaging session, whereas those who received stress reduction tended to have a decrease in their stress-associated neural activity. Now, what is especially interesting to me is there's a trend here, and it's only 9 patients, but the effect seems to be primarily driven by changes in amygdala activity. So those who were waitlisted had higher amygdala activity. Those who went through the intervention had lower amygdala activity. So thinking back to the effects of exercise, you could argue that if there's a way to target both the amygdala and the prefrontal cortex, you might get a synergistic effect on these downstream consequences. So to be discussed in a second. We also have launched a study now where we're looking in PTSD at the impact of chronic processing therapy on these same pathways. So in a collaboration with a psychologist who's focused on cardiovascular effects in PTSD, we are planning to recruit 30 patients, perform the same imaging and biometric evaluations, and randomize those folks to cognitive processing therapy with the hopes that this will give us some insights into cardiovascular benefits of treating PTSD. In collaboration with one of my mentors who's very big into yoga and breathing exercises, we're considering adding a breathing intervention into this study as well. So some of our future directions, we want to continue to leverage the biobank, thinking about the interplay between genetic risk, common stressors, and lifestyle, and how that may impact some of these important endpoints. I'm very interested in continuing to evaluate therapies. So going back a little bit to that notion of increasing PFC activity while decreasing amygdala activity, the idea of a combined intervention of exercise and stress reduction may give you synergy on this pathway, may explain those findings from that cardiac rehab study that they showed an improvement in MACE. There's also obviously some pharmacotherapies we could study. For example, ketamine appears to have a very profound impact on the amygdala. Not something that we're ready to deploy in the broad population, but maybe people with very advanced stress-associated conditions that could be fodder for study. I'm also, as mentioned by that statin study, very interested in thinking about how chronic stress exposure impacts treatment response. I don't think, based on our data, you could argue that the cancer data is suggestive of a differential treatment response. The statin data is suggestive of a differential treatment response. So really, any of these conditions that are prone to inflammation, and I know Dr. Burney's in the audience, but maybe even sarcoid, you could argue that folks with higher SNA may have a lower response to medical therapy for sarcoidosis. And then obviously, FDG is only going to take us so far. So I think we need to be thinking about other radio tracers that are going to provide further insights into this pathway. So I really appreciate your, I'm sorry, here's my conclusions. I'm not going to jump in just yet. So just going over things very briefly, FDG PET can be leveraged to look at metabolic activity in a number of multiple tissues, and that can be used to understand underlying pathophysiologic pathways. We know that chronic stress is linked to a number of disease processes and that the mechanism involves neural centers and a neuroimmune axis. We also know that several upstream drivers have been identified that drive this pathway, and that there appear to be several important and potential therapies that could modify this pathway. So now I'll thank you for your attention, and I just want to acknowledge all of my many mentors who have been extremely patient and helpful in my early career, as well as my collaborators who have made all of this possible.
Thanks, Mike. That was really wonderful and educational. And maybe with that stress of that recent study, you should get your own amygdala checked.
Yeah, I know.
It's now open for questions. If anybody has specific questions, I have the mic, Peter. Yeah. And Ellie's watching the chat, and people can also put their hands up online.
Great. Yeah, thanks, Rob. And yeah, so Mike is just fantastic. It's of course, we're totally biased here with really interested in brain and heart. So that's music to our ears, but it's below that threshold of 55. And one of the striking things that we previously looked at in the Ontario population of 12 million, looking at the ethnic and immigrant risk of developing cardiovascular disease, the traditional risk factors are observed, but one of the most striking one, which we could not actually figure out how to write on, is actually recent immigrants who actually come from war-torn regions. It's actually it's sky high risk. It's so obviously related to this, but we didn't quite figure out. So maybe this is a opportunity to actually begin to dissect that out. Yeah. So this is absolutely amazing. The fact that you could actually potentially modulate this. With you can modulate your brain structure and function, right? Through external strategies. This is just unbelievable. And so my question is, how stable, the question is how much is this inborn, in that, let's say, that Takotsubo is such a great example, right? Am I, it's just so stress prone that it doesn't matter, what happens, I'm just born this way? Or if you think that there is a very strong, sort of environmental influence to this, and so that you can still,
Yeah, that's a wonderful question. And I think we're starting to try to tease that out. So one of the studies I'm working on right now is looking at the interplay between socioeconomic status and neuroticism polygenic risk score. And our data is not near ready for presentation, but we can say that among individuals with high neuroticism polygenic risk score, the addition of adverse socioeconomic status makes their risk sky high. So it does seem that it's sort of both a seed and soil sort of situation. So if you take somebody who's very prone to these situations, or prone to a high stress response, they're going to have, and you give them a lot of stress, they're going to have more adverse effects. So it does really get back to, kind of this notion of potentially personalized medicine in a way. If you could identify these people from a relatively early stage, now even in Massachusetts, they're starting to teach mindfulness techniques in elementary school. So you could sort of start targeting these people very early on, so they develop positive coping strategies and try to attenuate some of these impacts. But I think that's a great question. Yeah.
I also wonder what the impact of presidential candidates.
Well, we know that elections definitely increase cardiovascular events, so you could argue that some of this is contributing to that as well.
I have two quick questions. How do you know that it's actually like you're showing these relationships, that it's really cause and effect? Like, how do we ensure that we're actually looking at that as opposed to epiphenomena?
Yeah.
And the other question is, you show this modeling, which is interesting, this stepwise modeling. Yet the main factor, stress, say, and MACE, that's not significant, but these other steps are. So I have a trouble wrapping my head around how that indicates that it is related.
Okay, so I think what we, certainly from the retrospective data, epiphenomenon is possible. I think from some of those other studies that were done by other groups where they imaged people, let's say at the time of their first stroke, and found that their SNA at the time of their first stroke predicted a subsequent stroke. Certainly those people are at risk, but the fact that it still remained predictive down the line, to me, suggests that this is more causal. I think we do need more follow-up data on individuals to ensure that this actually is a cause and effect. Causal mediation is certainly an imperfect way of analyzing this, but it's one of the better tools that we have for retrospective data. To get back to your other point, so with the indirect and direct pathways, so if your indirect pathway is significant, it argues that that pathway is very important in the link to between A and B, right? However, the direct pathway is the relationship that we already know. So what mediation actually allows you to assess is what percentage or what amount of that known relationship is accounted for by this pathway. So there can certainly still be a trend, but when the significance goes away, it suggests that you're accounting for most of the relationship through that indirect pathway. Does that answer the question?
Yeah.
Okay. Yeah.
All right, Ian, last question. Go ahead.
Thank you for that presentation. It was very thought-provoking. One of my interests, which I mentioned yesterday too, is cardio-oncology. And these patients, survivors of cancer, as you know, are at high risk for cardiovascular disease. Interestingly, not some of the cancer types are at risk for MI, but many are not actually. So it'd be interesting to look at, so in particular, hematologic malignancies seem to be at higher risk for myocardial events. So I would wonder, looking back at the PET scans for these patients, if there was any sign there, signal there, because when we've looked at population studies and accounted for all the traditional cardiovascular risk factors, there still is an excess risk in these patients we're not accounting for. And so this might explain some of that risk. They go through hell. These hematologic malignancy patients, they get through bone marrow transplants. I see them before and after. It's very hard on them. So it would be interesting to look at.
Yeah, kind of getting to that point, we're starting to look a little bit, and that's a great question, great point. We've started to look a little bit about the interplay between CHIP, so clonal hematopoiesis of indeterminate potential, as you all know, and some of these pathways. So I don't know, do any of these hematologic malignancies, are they carriers of CHIP? That could be another potential contributor, but you could argue that combination that's driving proliferation through stress plus, sort of this adverse hematologic profile could certainly be enough to increase atherosclerotic risk. That's a great point. But yeah, sort of touching on that, I think, the potential for looking at treatments and the impact of treatments in different groups is quite high, because really inflammation is the root of all evil, right? So you could think about, response to infections. You could think about a number of different avenues where this may be participating.
All right, I think we'll call it. We're a bit past the time. Thank you, everyone. As a great rounds, very thought-provoking. And so Mike is here with the residents for the next 25 minutes or so, if they're available. And then we'll be here for the rest of the day to visit. Thank you again. Have a great day.
Thanks, everyone.